Good evening, everyone, and welcome to the Swiss Neurogastro Webinar Series this evening. We are, as we have been in the last year, we are generously supported by LaserMed on this topic, and this is very topical with the reflux monitoring system. You will see this slide again. Today, what we are talking about is GERD diagnostic workup, and I have the great pleasure of introducing you to two speakers today with Dr. Radu Tutuian. He is the head of division of Gastroenterology and Hepatology in Solothurn. It looks like he's driving a car, but he has assured us that he is parked in a safe position. The traffic just precluded him from reaching home in time. And I also have the great pleasure of introducing Dr. Ginette Fotsing, who is a gastroenterologist and specialist in clinical nutrition at GastroGeb in Lausanne. They will be talking today about the diagnostic workup in gastroesophageal reflux disease. And a couple of housekeeping. So they will have two presentations. First will be Dr. Fotsing, followed by Dr. Tutuian, and in the end, we will be open for questions, answers, and discussions, and I'm looking forward to this webinar. I will now leave the screen over to Dr. Fotsing. Please take it away.
Thank you to the SwissNGM group, and thank you for asking me to do this presentation. It's a great pleasure. I share my screen. I hope it works.
Yes,
so
perfect.
I'll talk about GERD, diagnostic workup, and I have no conflict of interest about this topic first. And I want it to be an interactive workshop, but it will not be so interactive, but I will just ask some questions and maybe you can think about it in your mind and try to respond it. We start with Mr. P, 30 years old, IT developer with no comorbidities, normal weight, a little smoker, and experienced heartburn, especially during weekends and sometimes epigastric pain. No other symptoms, and he asked for endoscopy because one of his cousins died for esophageal cancer. And in this case, it seems to be a very simple question do you perform an EGD, a gastroscopy in a patient with little symptoms, 6 months of typical heartburn. The GERD has an estimated worldwide prevalence, very high. It was one of the major disease in general practice and in gastroenterology. It involves all gender, all age, and most of the guidelines had an empirical approach with the PPI trial because it's less costly and less harmful than diagnosis testing. It's effective even if there is non-GERD pathology, but it has very risk to over-treatment and PPI dependency. And so on, the first Lyon consensus was published in 2018 to determine the modern indications for esophageal testing in GERD and to define criteria for clinical diagnosis of GERD. The pathophysiology, it will be very, very rapid because GERD is defined by Montreal consensus, but about the reflux of stomach content into the esophagus. And what is very important is that this reflux has to cause troublesome symptoms and or complications, because that implies that the reflux from stomach to esophagus can be physiological, and you have to determine the frontier between the physiological stages and the disease. There is many mechanisms involved in this disease. The failure of the anti-reflux barrier, the alteration of clearance esophageal, the composition of the reflux material, but less research on this topic, the slowing of the gastric emptying, the alteration of the esophageal mucosa, and of course, a disorder on gut-brain interaction causing to esophageal hypersensitivity. And in common practice, there is a wide spectrum of symptoms characterized as GERD. And above all these symptoms, in which one could be acceptable to initiate an anti-secretory trial without any test? If you have epigastric pain, regurgitation, belching, heartburn, laryngitis, cough, asthma. The true response is that, but the real response is that almost all these symptoms are treated by PPI trial like acidity. But in line consensus, the troublesome symptoms are typical, requiring a test, a treatment test without any other investigation, are heartburn, regurgitation, and esophageal chest pain. But there is no optimal dose or duration recommended. The symptoms triggering for endoscopy are very common: dysphagia, bleeding, anemia, weight loss. But in the most recent ASGE guidelines on GERD in February this year, they add some particular cases when you have to do some endoscopy without any red flags, patient at risk of Barrett esophagus, and the special condition of post-sleeve gastrectomy and post-POEM, because they are known to be very high risk of esophagitis and gastric reflux. And in the patients at risk of Barrett esophagus, you have the family history of Barrett esophagus and esophageal carcinoma. Patients with more than 15 years, male sex, white rice, smoking, and obesity. It's like a lot of patients, but these patients are at risk. And so this simple question with our patient with typical symptoms and no other, if you follow these guidelines, you have to do an endoscopy to this patient due to the smoking and the family history. In a patient already on PPI, this is very classic question: how long should the treatment be stopped before the endoscopy? And the line consensus recommend 2 to 4 weeks to rule out, to see if you have very GERD evidence in endoscopy. Another much more complex case, it's Miss B, 51 years old, with hypertension, overweight or like little obesity, no smoking, little alcohol, typical heartburn, especially when she has some stress since 2-3 years, an episodic episode of solid food dysphagia, thoracic chest pain when she eats quickly, and she has tried PPI but not very consistent. We do endoscopy, we find a hiatal hernia, an esophagitis grade A, no eosinophilic esophagitis, and we start esomeprazole 40 mg for 1 month, then decrease to 20 mg by day. 3 months later, she said that at 40 mg everything was perfect, but 20 mg both. And when I stopped, I relapsed in 4 days. And she doesn't want to be on PPI therapy. It's very classic, very common. She has fear of osteoporosis, and she wants surgery or another radical treatment. So for this type of patient, will you refer her to surgery? Because she has hiatal hernia and esophagitis. But no, she has only 1 month of PPI, we should try harder. And we need to do some tests before. or the GERD diagnosis is not confirmed. According to Lyon consensus, the GERD diagnosis is not confirmed because the GERD evidence in endoscopy involves esophagitis grade B, C, or D, according to Los Angeles classification, Barrett esophagus biopsy proven, or a very clear peptic structure. And the presence of a hiatal hernia, it can also be an adjunctive element when GERD is inconclusive. And if you have an absent GERD, an unproven GERD, not an absent, you have to do some additional testing. And I will just make a review of the testing, starting with the less, less evident testing in GERD, which is high resolution motility, but we are in SwissNGM group. We have to talk about HRM. If you talk about esophagus, you have to talk about high resolution manometry. In GERD, the indication are to rule out a major esophageal motility disorder like achalasia to type 1 with regurgitation, which is not regurgitation due to a GERD, but regurgitation due to the esophagus. And you can also provide additional elements to understand or conclude in favor of GERD, the EGG morphology and the peristaltic function, and you can add some postprandial measurement. You know the EGD morphology in HMM, the three types of gastrointestinal junction, gastroesophageal junction, with the type 2 is a very big hiatal hernia, more than 3 centimeters, and which is associated with a reduced pressure of the lower esophageal sphincter and correlates with reflux severity. You can also study the peristaltic function with the strong definition by the Chicago classification of ineffective esophageal motility. And you can also have additional elements such as contraction reserve, and I will let the Mellens go for further. In HRM, Mrs. B has a junction of type 2 with hypotonic LES, and normal other features, everything was normal. You can also have ambulatory pH monitoring, of course, pH metry or pH impedance metry, which can be catheter-based or wireless. Go to 24 hours, it was the minimum. Up to 96 hours will provide a very useful additional element, and the pH metry gives information about esophageal acid exposure and correlation between symptoms and acid exposure, but it's less useful if it's done on treatment. Impedance metry gives much more information about what's happening in what's transit in the esophagus. But you need an HRM before the test for catheter placement. But the availability and the time-consuming analysis, depending on the software, can have some limitation. How do you want to do? Do you have to do on or off PPI of treatment if you want to determine the presence of a GERD, or on treatment in an already proven GERD, want to understand why the treatment is ineffective? And in this specific case, it will be much more useful to do a pH impedance metry, because you have you can have much more symptoms analysis, correlation between symptoms and reflux and on. briefly, the pH impedance for the ones who don't know how it works. It's a qualitative analysis of esophageal content, the measurement of the esophageal conductivity between 2 points. And when there is a low ion content of the reflux, you have in 2 points, you have a high impedance. And when you have a high ion content, you have a low impedance. And if you couple that with the pH meter, you can see if there is liquid and if the liquid is acid or not. That is a software by Medtronic, and you can see in white this topographic version of the impedance, and the drop of impedance, you see a reflux, and the correlation with the pH, which is this line in red, you have an acid reflux. Otherwise, you can have this is in black. It's very high impedances, and this is a swallow of hair. This is multiple swallow. So in line consensus, there is threshold of GERD evidence in pH and in pH impedance metric. And there are some threshold of treatment, but also, and that's the new thing in between 2018 and 2024, is that you have this threshold on treatment, on pH impedance, on therapy. And you can have the difference between conclusive evidence for pathological reflux and evidence against pathological reflux. It's based on acid exposure time, total number of total refluxes, and mean nocturnal basal impedance. When you have some borderline or inconclusive evidence, you have some adjunctive element which can help you discriminate patients between all the spectrum of GERD disease. And one of the spectrum of GERD disease is that you have erosive esophagitis, non-erosive reflux disease, reflux hypersensitivity, and functional heartburn. And to discriminate in which patient you have to implement treatment, what kind of treatment, and do you have to do some anti-reflux surgery or whatever treatment you want to do. This is two very simple case of pH metry, simple pH metry. You have a male, 52 years, with regurgitations, mostly in the morning, few heartburn, and he has a little hiatus hernia and normal esophagus. And you have a very high acid exposure time. We're thinking that I have a catheter displacement, that is not that the catheter was placed, and you have a very, very high exposure acid. And in this case, you have non-erosive reflux disease. And you have this female, 25 years old, with heartburn despite isomeprazole. The endoscopy is normal. Excuse me. In pH metry, you have acid exposure term of 3.2, which is below the 6% of the line consensus now. But if you see the symptoms association, excuse me? Okay. If you see the symptom association, you have a very strong symptoms association. You have this reflux hypersensitivity. In Mrs. B, this patient with this hernia and esophagitis grade A, the 24 hours pH of treatment, She has AET of 2%, number of reflex 48, and she seems to have no GERD. But the only factor which is seems to be interesting and is the mean nocturnal basal impedance of 800 ohms. And just a few words about this MNBI. It's correlated with the reduction of esophageal impedance is due to this mucosal damage of acid or whatever reflux content with the increased permeability of the esophagus. And this mean impedance correlates with basal esophageal impedance in 8 hours, with total acid exposure and the severity of lesion, and can predict PPI response. The cutoff, it depends on a lot of studies we have done, but there is two cutoffs. The cutoff under 1050, you must have some mucosal damage, and above 2,500 ohms, you must have a mucosal integrity who is much more seen in healthy subjects. Some regional, maybe racial difference can exist, and the post-swallow peristaltic wave index in lion consensus is still not validated, so I will not talk about it. So the Lion consensus, the new Lion consensus, gives us much more detailed cutoff, much more detailed element to diagnose if there is really a GERD, not really a GERD, on different exams, on different testing, which is endoscopy, pH or pH impedance, high resolution manometry. The cutoff for the test on treatment, which is very, very important, and some adjunctive element. And I will give the talk to Professor Tutuian to go further, because we can go, I think, very further, and there is very, very interesting new element for these borderline patients or inconclusive patients. Thank you.
Well, Ginette, thank you very much for this excellent overview, and really with real cases from your practice. I think this is really an interesting topic. In order to stay in time, since we are going on recording, I would like to go through a few things, pick up where Ginette has led us with her definition, and sort of see what is now beyond Lyon 2.0. You all know this came out last year, and the presentation, sort of, it was first published late 2023, the online first, and then since 2024 we use this new consensus. Ginette has shown you this figure from the paper on the approach to evaluate patients with GERD symptoms. I think what Lyon 2 really puts now sort of on paper, if you want, and gives a detail, is sort of how to approach patients based on their symptoms. And again, the idea is that if you have young patients without alarm symptoms, with typical reflux symptoms, that is heartburn, regurgitation, and esophageal, that means non-cardiac chest pain, probably the first approach will be an empiric treatment with anti-secretory therapy. We use PPIs. We'll see whether PCABs will have a role into this. H2 blockers, at least in Switzerland, we don't have access to it. So we talk about now PPI therapies. And this step is usually done by family physicians already. And I guess the majority of patients that we see in our practices have been through this therapy trial of PPI therapy. And then, as Ginette has nicely put it in perspective, we usually, personally, we take the endoscopy report from the colleagues, since we acknowledge that the endoscopy is really done accurately, and we focus on the findings of the esophagus, see whether they mentioned or not the presence of esophagitis or not. And then sort of we go for the additional testing, wireless pH monitoring, pH impedance, or HRM, and we're going to go through this a little bit different now. Now, the idea from the Lyon 2 is sort of once you have patients with no typical symptoms, that means you have patients with atypical symptoms like belching, chronic cough, asthma, and all the ENT plus epigastric type of pains. The idea is that there is no reason to treat these patients empirically with PPIs, and you should probably go first to physiologic testing, provided that the endoscopy doesn't provide you a diagnosis. So here, these patients should be probably tested before any therapy is involved. As you probably all know, there's only a minority, that means probably less than 1 in 4 patients who will have reflux as cause of their symptoms. And probably in most patients, we will have to deal with this adjunctive approach to their symptoms. The second point is really in the Lyon 2 is really the how to test based on the previous evidence of reflux. And Ginette has nicely picked 2 cases which showed findings that we see them every day on endoscopy. Here we can probably discuss in the Q&A what do we do with these patients with, let's say, if they have ultra short Barrett, like 1 millimeter or 5 millimeters of Barrett, and do they ever then have the GERD diagnosis or not? Maybe that's one point of discussion. But anyhow, if you have, let's say, severe esophagitis done previously, then there is evidence of GERD. So there's no point in really testing these patients to prove if they have GERD. What you can though test is now if these patients have ongoing symptoms, whether the symptoms are due to ongoing reflux or if the symptoms are not due to reflux. And here, impedance pH is actually better than conventional or wireless pH monitoring, since it gives you the information also on the non-acid reflux episodes. If you don't have evidence for reflux and none of the findings that you have in the middle, then the question is, do these patients have GERD in the first place? And I think if you don't have any severe esophagitis, it's probably safe to take these patients off PPI therapy and test them then without therapy. Ginette has put it very nicely, sort of you should have them 2 to 4 weeks. Probably that's good for lesions. In terms of esophageal testing, 1 week of PPI therapy is probably enough. And I don't know how your practices are. I'm going to be curious to see in the Q&A, but we take them off 1 week of the PPI before testing them. And here we can use both wireless or catheter-based testing, and there are some data suggesting that wireless might be actually offering some advantage on that. Now, Ginette showed you also this table on the Lyon 2, and I think this is really a very nice summary on the findings, endoscopy, impedance with or without pH, and manometry of and non-PPI therapy, and what are at the moment the conclusive evidence for reflux, what's evidence against reflux, and then we have this findings where we can discuss whether this should be borderline conclusive or adjunctive, regardless of. I think these are these findings here, which we fight, and we don't know how to weigh these findings in if they are the only ones that have the diagnosis of GERD. Now, this is a summary sort of how we go. Sort of you have acid exposure, a number of reflux episodes, and baseline impedance. These are the parameters that are agreed upon on impedance pH monitoring in the Lyon 0.2. And again, here you have normal findings, you have abnormal findings, but equally you have this kind of borderline in between which no one knows exactly where are they or are they not abnormal. With the symptom association, you can either use a symptom index, or if you prefer like the general consensus to use, the SAP. Keep in mind that SI is positive, it's more than 50%. SAP should be more than 95% in order to be called positive. Now, let's take a look on what we have beyond this stage. One thing is this Milan score, and maybe we can pull the audience. I'm curious to see, do you guys have used this score? And if you can raise your hand in the chat, I can see on the overview if you have it or not. So like you would raise your hand to say something. So it's in the let's see, show chat, main chat. Luis Gerardo is saying leg raise. Yes, it's not in the standard protocol. Okay, so it's either you didn't find the button or you don't use it. I guess you probably do not use it. Now, this is a study that was published again last year from an Italian group, and the aim of the study was to see if you have a predictive model in the HRM to predict the presence or absence of reflux. It's actually a very nicely done study if you read the publication. They had actually two cohorts. They had one cohort which they used to calibrate the score, and that has a considerable number of close to 300 patients. And they also did a second cohort, a validation cohort, to see how well the score performs. And what they looked at this on the right table. You see the parameters that they looked at. They looked at the multiple logistic regression model and look whether these patients had IEM, whether they had this straight leg reflex maneuver, the EGJ contraction integral, the EGJ type, whether it was 2 or 3. If you look at this table, you'll see that probably the highest way is this straight leg maneuver. That means that patients are asked to elevate their legs straight while they are lying down. And what you do, you measure the difference in the intragastric pressure before and during the straight leg reflex and see if this pressure also changes in the esophagus. Now, what you see here are these two, if you want, extreme scenarios with high and low probability for GERD. You can see in the left side of the screen, you see a patient who has a normal contraction, at least depicted here. And on the right side of the screen, you see how the patient raises the legs, so increases the abdominal pressure. You see the increased tone in the EG junction, and you see that there is no increase in intrathoracic pressure. So they have this normogram that you can then calculate based on the presence or not of IEM, then the straight leg reflex, if it's present or not, and then you can draw here a score. And this one will give you a predictive value now on how likely it is that this patient has GERD. And in this example, the patient has a probability of less than 30%, somewhere between 25 and 27%. So that's a relatively low probability of GERD. On the right side, you can see this other patient who has a weak contraction, what they show here. And again, during the straight leg reflex, you see a rise in the intra-abdominal pressure. Equally, you see this pressure increase also in the intrathoracic, and this will be a straight leg test, which is positive now. So if you, again, calculate using the normogram, you will get a probability of 84% of this patient having a reflux, making him a high probability for having reflux. Now, these are the results from the paper. They looked at how well this Milan scores predicts abnormal acid exposure time. That's that's acid exposure time more than 6%. And in the calibration cohort, they found an area under the curve of 0.88, which is quite a good discrimination. power. And also in the validation cohort, they found the same area, suggesting that this test is actually fairly good in identifying the patients who have abnormal reflux based just on a test done during manometry. To be honest, we are currently investigating. We are trying to see whether we have this study, and we hope to be soon able to present at least some studies on how this performs outside academic Italian centers. It's also easy. I mean, the study group went so far that they created a website. It's called milanscore.com, and where you can actually insert all your values, and then you get a score and the likelihood and also the risk classification. I have to say they've done a very nice job on sort of being able to access this from anywhere. And to be honest, this is also what I use when I calculate the Milan score on that. The second study that I would like to present is this study published in Disease of the Esophagus from South America, and they looked at what is the value of prolonged wireless pH monitoring in patients with reflux symptoms and borderline 24 impedance pH. They went exactly for this group. That means they took patients who had refractory reflux with borderline acid exposure, and that's between 4 and 6. They did a GERD-Q questionnaire. Then all these patients underwent a 96, a 4-day wireless pH monitoring, and they were separated into patients with GERD. That means if they had at least on 2 days an acid exposure time more than 6%, or no GERD if all their days were normal. So that means acid exposure time less than 4%. And in these patients, they went and upped the dose of PPI, whereas in patients who did not have reflux, they did some neuromodulation in these patients, and then they reassessed GERD-Q afterwards. Now, what they found, they had a group of 30 patients with typical persistent symptoms on PPI once a day. And when they were taking off PPI therapy and had an impedance pH monitoring, they had an acid exposure time of 4 to 6%. And these patients underwent a 96-hour capsule pH off PPI therapy. And what they found was that about half of the patients, that's 16 out of 30, that's 53%, they had evidence of GERD. That means on at least 2 days of wireless pH monitoring, their acid exposure time was more than 6%. That 20%, that means 1/5 of the patients had no evidence of GERD, and still had about a quarter of their patients where there was 1 day abnormal, and the rest of the days they were normal. So if you look at this, what they call this wave flow group, you see that a group of patients that had reflux, that means they had abnormal pH, so abnormal exposure time more than 6%. Then you had a group of patients that stayed all the days, they stayed below 4%, and you had a few patients who changed. They had only 1 day above 6, and these were the borderlines. So on the right side here, you see again this data, again suggesting that probably in patients where we get a borderline impedance pH result, then you probably half of them truly will have GERD, while only 1/4 will not have GERD, and 1/4 will not know exactly what to say about them. It was interesting in this paper to also look at what are predictors in this for abnormal to segregate into these groups of GERD, non-GERD, and borderline based on the symptoms that they have. The downside of this is that the numbers are low, so you have to be very, very careful in sort of how to interpret this data. One of the things that stood out, although not statistically significant, is that, or borderline significant, is if the patients had atypical symptoms, mainly cough, the likelihood was higher to belong to this non-GERD group than to the other groups. In terms of the other symptoms, there was no predictor. Again, hints, but no statistical evidence on ends of 16, 6, and 8, is that the total number of reflux episodes seems to play a role. So if you had more than 80, you had a higher probability to be in the GERD group or the borderline group, as opposed to the non-GERD group. If you had low mean nocturnal baseline impedance, that's what also Ginette showed in her case. If you have low mean nocturnal baseline impedance, you're more likely to be in the GERD group. That is probably one of the things that probably comes to see. This study should probably be repeated in a larger number of patients to see on what we get in this group. Now, the latest study, Lyon 2 or Lyon score, here again, raising hands, who has or who's using this already? Okay. Nora says thumbs down. So Nora says she doesn't like it. We'll get to this in a second. Now, again, study published in the Red Journal just in May, so it's really brand of the press. It's a joint U.S., Italian, European, and Asian study. Again, with two cohorts, one large cohort in patients with typical reflux symptoms from Europe and the US, where they had data on endoscopy, HRM, impedance, pH, and symptoms before and after reflux therapy. They had a mix of surgical and medical therapies. And then a validation cohort. These are 250 patients with typical symptoms from two centers, one in Italy and one in Taiwan. Again, with the same data on endoscopy, manometry, reflux monitoring, and symptoms before and after anti-reflux therapy. And what they try to find is sort of what can we come up with a score based on the Lyon 2 criteria, which will help us or predict a 50% improvement in global symptom severity. So if they have a VAS scale where they say, well, how bad are your symptoms? If the patient had before or after treatment could have been PPI-QD, PPI-BID, and/or fundoplication. And if they got 50% more, then they said, well, we predict the therapy. Now, the way that they did with the validation cohort and what they came up with was attributing points to each of these findings from the Lyon 2.0. So if you had no esophagitis, remind you that this is the evidence against GERD in the Lyon 2 consensus, then you got no points. If you have an esophagitis type A, that's a supportive criterion, you got 2 points. If you have LAB, you get 4.5, LAC 5.5, and 6.5 points if you have an LAD. Then also they scored the acid exposure time. Again, they gave if they had acid exposure times more than 6%, they gave it 4.5 points. If they had more than 10%, they said, well, that's severe, and they got 5 points. And they got 3.5 points if they were in this borderline area. Same they did for a number of reflux episodes, more than 40. And they looked now also at main nocturnal baseline impedance and the symptom association probability. Again, positive got 1.5 points. If negative, that was 0. What did they find? They found, you see here the response rates to anti-reflux therapies, PPIs and/or fundoplication. And you can see this is the developmental cohort, then you get the European validation cohort and an Asian validation cohort. And you can see here that, the higher points you get, the more likely it is that you get a response to anti-reflux therapy. Patients with functional heartburn, they had virtually no response. Also, the permeability defect, this is only low MNBI, reflux sensitivity, and inconclusive GERD. What gets a little bit in the way are this Asian population group, which doesn't seem to follow the same pattern as the European and North American group. And this is also the result here. You can see the ROC curve again, looking at the Lyon score. And also what they factored in was the Demister score, the old time-honored reflux score that the surgeons are using to discriminate response to therapy. And they found that the Lyon score and the Demistre score, they had very good AOCs, that's 0.8. In the European validation cohort, the area under the Lyon score was 0.9. Interestingly, the Demistre score actually a little bit outperformed the Lyon score, if you want. And again, this is a little bit sort of that probably needs to be discussed and explained. Why did they have a validation cohort that was so bad in the Asian population? You see here the results of the area under the curve with sensitivity specificity using different cutoffs. And what you can see here is that, again, in the European cohort, this score seems to be performing very well. Although I have to say that if you look at the numbers and compared to the other scores, they are probably similar to that. Sort of in summary, if you want, sort of this course actually tries to help to put some weight into this. If you see this in this Lyon 2.0 in this area over here, where we have this gray and orange groups where we don't know exactly what to do. They attribute some points to these groups, and they suggest that with this score you can probably predict a little bit better the therapy outcome. So to take home message to sum this up is really we got the Lyon consensus now. I think that that should be used, and we consequently use this in our approach. Then we have to see what we have to do with this Milan score. It's a fairly easy thing to do. You just have to take the patient to raise their legs before you sit them up during manometry, and if you think about this, it's not doesn't prolong your manometry too much. Then the prolonged wireless pH monitoring seems to be offering a clue. That means that patients with borderline acid exposure are more likely to truly have reflux and not be functional or no GERD. And the Lyon score, which probably also needs to be sort of, it just came out. We need to see and we need to understand exactly how we can use this in indicating therapies for our patients. That was now my part. So I think we got now to the question and answer section.
Great. Thank you so much to both of you for the great presentations and the great overview. Here again, also a thank you to LaserMed for sponsoring this. And I think I would like to open this now for further discussion. So if you want to contribute, feel free to add your question in the chat or raise your hand. While people are getting ready, I think they didn't find the hand during your questions, Radu, so I'll give them some time to look for the hand. One question that I have is, Ginette, you mentioned that, you both mentioned that oftentimes these patients come to us and they actually already had some sort of PPI by the general practitioner. And we also know that many of these patients have never been properly instructed when to take their PPI. And I wonder, is that something you do routinely to first establish that they're taking it well? How do you instruct them? Or do you already kick off your algorithm when these patients see you?
Thank you. That's very, very interesting, because most of them, and that's why I show in the second case, she said that I have GERD and I don't respond to PPI. And if you ask the patient, and that's the first thing to do, is what have you taken, when, and for how long? And sometimes I don't respond to PPI treatment, or I don't, is that they are taking that occasionally, they are taking it because with the meal, they are taking it in the evening before to go to bed, or they are taking it and they respond to the treatment, that when they stop the treatment, the symptoms relapse and they say it doesn't work. So that is different type of I don't respond to therapy. And so the proper thing is to ask them when you have to take it. In the morning, 30 minutes before the first meal. That's how, when the activity is much more important. The doses is very specific also, and sometimes to switch the PPI for some responder, and for some people who has taken PPI for certain time, if you stop very abruptly, very quickly, you have a rebound of acidity, and so it's important to decrease the dose. So all these features are very important on how when you say this patient is refractory to PPI, and that's why even when I do endoscopy for a patient who has some GERD refractory to PPI, after the endoscopy, he goes with PPI and properly ask how to take it.
I completely agree with Ginette. I think we're encountering exactly the same situations on compliance to PPI. And I think, Lukas, you're addressing an excellent point here. Majority of patients will take in the morning because that's what the doctor told them, but they don't take breakfast. So that's one of the really common things that that we see. The second thing, what also Ginette was telling us, sort of they take in the evening before they go to bed, but not before dinner. And I think these are two main issues. Now, we don't get to see the patients before testing. So usually we get them at the time of testing. So we, at least in our lab, we don't address this prior to that. We try as much as we can to get from the referral letter to understand what evidence of GERD it is or not, whether or not to tell them to get off the PPIs or stay on PPIs. And that helps us a little bit when we see them, because we do before every testing, we do a consultation, and usually we ask them that, so how was this week when you truly stopped the PPIs? And I think we get there a little bit sort of the information on how it is at least 1 week of stopping PPIs to see whether they, some of them will come and say, well, actually, I never thought it was helping, but now that I stopped them, it actually feel worse than when I was taking them. So they revise a little bit sort of their point on whether or not they responded to the PPI or not.
Yeah, very valuable inputs. Thank you so much. I see that Luis has his hand raised.
He was first.
Hello. First, thank you very much for the presentation and for inviting me to this amazing talk. I was wondering about the Milan score, because at our center, usually patients get referred for both tests at the same time. I mean, they get the manometer first, and then they get the pH catheter placed. So I understand that Milan score is very good at predicting acid exposure, but my question is, in clinical practice, what does it add if the patient is already getting the catheter?
Well, I think we sometimes get referrals from surgeons that they say, well, I already have an LAC, so I want to test to see if there's a motility study or not. Or we get them with Barrett and they want to operate on them. And then usually I think that if we get the referral just for or they have patients with atypical symptoms and they say, well, he has a hernia and I'm going to fix the hernia. And then I want to know just if there's a manometry, the motility is abnormal, so I don't wrap too tight my fundoplication. So we had a few instances where we actually used the score and then we said, well, the score suggests a low probability, at least on the evidence of data that we have at the moment in literature. Consider please to do a pH before you go ahead and operate. So it is sometimes if they, yes, and I agree with you, that once they get both tests, and probably the added value is not that much. We do it because we want to really we're a bit sort of not that believers, and then we want to see if that's really piling out like it is. And if it is, then I think then we can discuss whether or not we need to do the reflux monitoring if this test would perform that well as the Italians are suggesting.
Thank you.
And then I see that Gilles also has his hand up.
There is
Please.
Giles.
Yeah, hi. Thank you for hi,
Oh.
hello everybody. Thank you for really nice talks. I really appreciate it. It's nice to hear this stuff. I've been away for a bit. I really like with the Lyon consensus the idea of these symptoms that are unlikely or less likely to be reflux, because we all know that real reflux responds to PPIs and that we don't need to reinvent that wheel. So it follows on a bit from Radu's point. If we're testing, are we looking for people who might respond to surgery with atypical symptoms? Is that what we're looking for? And I reflect on, just while you're thinking about that, on that last paper that you posed, we have this nice ROC curve, but a proportion of those people will be people who definitely have reflux, who have definitely responded to PPIs, or will have got to surgery because they definitely have reflux. And that can bias the outcomes. And in a way, the interesting group are the people with atypical symptoms, but have strong physiological markers of reflux. How can we measure their symptom response? Is there any work on that and their quality of life? And what is that what you do for those people? I don't know who wants to take that first.
Ginette, do you want to go first?
No, I think that it's a question for you.
Yeah, well, no, exactly. That's exactly my point when I was reading the paper, because as you're pointing out, Gilles, they're really looking at the whole patients with clear reflux, and yes, they will respond. And I think in these patients, we don't need to fiddle around with additional scores and all that. But equally, I think the interesting group, and that will be really a thing to look into. I'm not aware that anyone has set up such a study, but really take, let's say, only these patients with borderlines and see whether we can here find predictors. Now, understand that for surgery, that's a tough intervention, and probably ethically it's going to be a little bit like this. But again, there is some evidence suggesting that, well, there is something abnormal, and to do it. I don't know whether there's always discussion about these endoscopic procedures, which are theoretically less invasive and less debilitating with less morbidity, but equally less efficiency. So I'm not sure whether that will give us the answer. But it will be interesting, sort of, to if this will and that's a nice value about collecting data from multiple centers, to get this information and at some point compile it in a larger group and see exactly this group, as you're saying, patients with atypical symptoms. Do they have predictors on reflux that respond to surgery? Because we know there's a small group of patients who will definitely benefit from surgery. The vast majority not, but it's probably somewhere around 10 to probably 20%, 25%. And here you can make a difference. And I think it's our job to find out which are these patients. Equally, our job to keep the others away from an operation which can get them more complications.
Sure. Okay, that's helpful. Thank you. Thank you for the talk, both of you.
Thanks.
Great. Thank you so much. I will check the chat. And I don't see any hands raised. I don't know if you had some final concluding remarks. Otherwise, we could start wrapping up more or less on time.
Yeah, no, I would really like to thank everyone who joined in this evening and for the interest. I think it's one thing that is, Ginette, really, it was a pleasure to co-host this webinar with you. And Lukas, thank you very much for your help setting us up for this, and also LaserMed for their support on that.
Yes, and with that, thank you very much, Radu. Thank you very much, Ginette, for these excellent talks, for this overview on a very important topic. Again, thank you, LaserMed, for the generous support of these webinars that we do with the SwissNGM. A small outlook for the upcoming 2 talks from SwissNGM will be in September. We will be covering the therapeutic options for gastroesophageal reflux disease, including surgical interventions, something that we briefly touched upon now in the Q&A session. And in November, we will be discussing constipation. If you already got the news, you will receive the news over the same channel, and otherwise you can reach out to info@SwissNGM.ch to be kept in the loop for these upcoming webinars. And with that, I thank you very much for your participation, and I wish you a lovely evening. Thank you. Bye.